Okay, everybody. So thanks for tuning in. I usually jump onto these live streams for about 20 or 30 minutes at a time. Sometimes on the weekend. I haven't done one of these in a little while. It's been pretty busy summer. But the thing I want to focus on today, and the theme I try to have for each of these is something a little different. But I'm going to kind of focus on the future of spine surgery and kind of what does that even mean? So what I think about the future of spine surgery is one, what do we think of the next couple of months, next couple of years, and maybe over the next decade, not too far in advance, in terms of diagnosing issues better and then treating things better. I think the diagnosis is a big part in terms of the treatment, because if we can get a good diagnosis, then we can have a better treatment. I know it sounds a little silly, but think of it similar to cancer treatment, where the way cancer treatments get better and more targeted is we're able to better understand which specific subset of a subset of a subset of cancer is, and then we can target drugs, modalities, treatments to that stuff. So with all that being said, today I'm going to talk about the future of diagnosing different spine issues, and then we're also going to talk about the different treatment options of those. And kind of here's what I'm excited about over the next couple months, next couple years. We'll go from there. So look, I like to usually start these with I'll definitely answer questions. I got about 1,000 people in the different platforms coming in. So I'm trying to read these questions while also trying to talk. But let's kind of back up 2 steps here and just go over a couple topics first. So in terms of the spine, we have the cervical spine, which is the neck. There's 7 bones in the neck. You have the thoracic spine, 12 bones in the thoracic spine. That's where the rib cage comes out. I just found my spine model. It's been missing on my in-laws' house for about a year. So I'm excited to get this back into, just kind of wondering, like, how do you lose a spine? And then this is the lumbar spine. We have 5. Some people have 6, a little debated. 5 vertebral bodies in the lumbar spine. So in terms of kind of getting people's questions and going over different topics, I think the thing that spine surgeons, pain doctors, chiropractic doctors, if we want to lump them in that category, people that kind of take care of the spine are going to do a better job of in the coming years, is identifying what's causing back pain better. Let me tell you what I mean by that. In general, back pain is caused by 3 things. Not 100% true, but 3 things cause back pain. You either have bone, disc bone, and bone-on-bone collapse, and these bones rubbing on each other cause a significant amount of back pain. You can get a disc herniation. Actually, I think I got a good disc herniation model. Oh, this one here. All right, let's see if I'm strong enough to make this disc herniation come out. Really got to crank it. So you see here, see if I squeeze it right there, that disc comes out. So a disc herniation, that in itself, the rupture of the disc space, as well as the nerve being pinched, spinal stenosis, can cause back pain. That also causes shooting down pain usually. But the idea of a disc herniation, and another thing that causes back pain, got my props back there as you guys can see, is something called spondylolisthesis. And that's my favorite thing to treat. That's where it goes bone, disc bone, and the bone's kind of sliding forward. That's another major source of back pain. Now, is that it? No. You can have infection. You can have an abscess. You can have a tumor. You can have a trauma, a fracture, gunshot wound. You know, there's a million things that can cause back pain. Don't get me wrong. But in terms of like what's the day-to-day things of back pain, usually those 3. Now, 2 others that cause back pain that I'm not really going to hyper focus on right now. You could have just muscle strains in the back, just from micro traumas, but muscle strains can cause back pain. And then I kind of touched on this a minute ago, but if it is bone on bone, normally you have this good curvature in the spine called lordosis. But if you are bone on bone, these discs are normally wedge shaped. They're fat in the front of the spine, skinnier in the back. So if you're bone on bone, if you have disc herniations, if you have spondylolisthesis, kind of all those 3 things I mentioned, you lose some of that curvature and you're hunched forward. Well, how do you fix this hunched forward? You're walking around life and you want to be able to look up, evolutionarily. All right, people stop doing that. Okay, so evolutionarily, how do we do that? We lean forward. Well, we couldn't do that. We couldn't see the predators and prey. So what do? We bent our knees, bent our hips to turn the spine back. You're flexing these muscles back here, flexing those muscles back here throughout the day, throughout the week, throughout the year, causes a lot of back pain. So it's something called pelvic parameters, and spinal balance is another source of back pain. So what's the future of spine surgery in terms of that? We're going to do a lot better job of diagnosing it. There's a special type of x-ray out there called an EOS, that are becoming more and more common practice, more and more commonplace. Some doctors, before every spine fusion or spine surgery, they're ordering an EOS to see the entire alignment of the spine. That's a big deal. So us getting a better diagnosis of the entire alignment of the spine is something the future of spine surgery is really focusing on. It's something that, maybe my more senior peers don't totally focus on as much as, those kind of coming out of training, because that's what we've been beaten into us, is looking at the hips, looking at the pelvic parameters. That's something that's pretty common from an orthopedic spine surgery training, and now it's becoming a lot more known and common in the neurosurgery spine training. So just in terms of the different paths to get there, we have us at ortho, we have a lot of hip and knee background, a lot of biomechanics is a huge part of orthopedics. And so just having maybe a greater focus on that throughout all of the spine surgery fields is something that the future of spine surgery is going to include. I'm going to take a little pause and we'll kind of go through there. From Nurse Jen, my cat's name is EOS. I didn't know that spine test had a name. And EOS stands for, oh goodness. Well, maybe I shouldn't say I know what it stands for. I don't know. It's a full standing thing. I'm sure someone will tell me, I'm like, oh yeah, that's right. That's like a full standing x-ray. We get it a lot of pediatric deformity. Someone can Google it and throw that in there. A couple other things there. What are my thoughts on the mild procedure? If a spine surgeon is doing a mild procedure, I'm okay with it. In general, I think the mild procedure is more of a marketing term, because you're like, oh, mild, it's going to be a small little spine surgery. Well, kind of at the end of the day, it's just a laminectomy, or they're just taking the ligaments and flavum. I think it's got a cute name. It's got a cute trademark. And if a spine surgeon is doing it, then they know what you really need. If a non-spine surgeon is doing your spine surgery and they're doing a mild procedure, then that to me is a non-spine surgeon doing spine surgery, not to call out any specific group. So something else in the future of spine surgery I'm really excited about. I say it's the future, but goodness gracious, we as spine surgeons have been doing these for 23 years at least, in terms of like modern disc replacement or disc replacements. I'm going to cover up the brand of this one because I don't want to advertise any particular brand, but this is a 2-level lumbar disc replacement. So it goes bone, disc replacement, bone, disc replacement. Disc replacements in the lumbar spine are a little debated, a little controversial. I'd say a lot controversial. What is not controversial, though, are cervical disc replacements. And when I tell my patients and people looking on, and appreciate the likes, shares coming through, I would think of it as like a hip replacement and a knee replacement, or they're kind of similar, but they're two totally different things. So a lumbar disc replacement, a key, is totally different than a cervical disc replacement. I love cervical disc replacements. I kind of wish that was the only surgery I did, but it's kind of a small subset of the surgeries I do, truthfully. Probably, I don't know, of the 30 surgeries I do a month, maybe 1 or 2 are cervical disc replacements. I wish there were more. It's just, I probably could indicate, well, how do I say that? I probably could do more if I wanted, but most people would be better with less or with a fusion. That's probably the best way to say that. There's tons of people, as you can imagine, from social media platforms that travel from international and they want a disc replacement. I'm sure I could take their hard-earned money to do a disc replacement, but truthfully, they need a fusion. I tell them they need a fusion, and I'm sure they'll go down the street or somewhere else to get that surgery that they're looking for. And nothing too wrong with that, but that's just part of it. So in terms of other future things, disc replacements are big, but the problem with disc replacements is that they don't take care of the joints in the back. So in terms of these facets in the back, that's where these bones rub. It's almost like the knee joint of the spine. Disc replacements only fix this part. If you're totally bone-on-bone collapse, if you have severe facet arthritis, the disc replacements aren't going to help that, and in fact, might make that work. So another study that us spine surgeons are utilizing more and more over the last 5 years, and I think we're going to keep using, is something called a SPECT CT. Now, not everyone should get that because it is a CT. It's even considered kind of a high dose amount of radiation, but a SPECT CT, SPECT, pretty much is used in oncology and tumor practices to see if you have rapid uptake of the dye. If you have rapid uptake of a dye, it's because of irritation or a tumor that's growing. That's how we commonly use it. But as spine surgeons, we actually sometimes use that to identify sources of back pain. And you can get that to see if different joints, either the left side, the right side, L4-5, L2-3, you can see if different joints are lighting up and if that's a source of your back pain. And that kind of helps us perfectly identify if there's a certain facet causing your pain. Now, doing spine surgery for back pain might not be the most ideal thing. And in terms of the future of spine surgery, I think I put that into that category also. Have we done surgery for pure back pain? Yeah, for sure. But if your issue is just back pain and you're looking for a spine surgery or spine fusion, that's not the most reliable fix. The most reliable fix from a spine surgery standpoint is radiculopathy, numbness and tingling running down, or something called spondylolisthesis, bones sliding back and forth like that. That's where spine surgery has the best outcomes. So I see a lot of comments coming in. I'm going to take a couple pause on the future of spine surgery, and specifically got about 1,000 people in the chat. I do appreciate the likes and shares. That helps promote this to your peers. I got a lot of props and models back here, including this one. This one's one of my favorite. A patient from Wisconsin. I think I'm butchering it. She's probably watching, and I completely apologize. I don't remember where you're from, but she sent me this. My God, if I break this on national TV, look how cool this is. Oh my God. It's a woolly mammoth fossil bone. It's the C2, the cervical 2. So hold on. Can't drop things on a recorded thing. One, I'll have no patience, and two, be really sad. But in the cervical spine, that's this bone way up here, the C2 bone. And one of my patients flew all the way across America, did a great surgery on her. Actually, she's had surgery with one of my buddies for a hip replacement also, or a knee replacement, I forget. But this is the C2 bone of a woolly mammoth. Pretty cool. Gotta be really careful. She actually sent me this also. This is a bear fossil, thoracic bone. Anyway, patients sent me a lot of cool gifts, and I really appreciate that. So enough about me. Let me talk about y'all. I see a couple questions coming in. What do you do about pars fractures and spondylolisthesis? That's a great question. A pars fracture for real is my favorite condition to treat. Just because you have a pars fracture does not mean you need surgery. So if you see that on your MRI or CT, you don't need surgery just because you have that. But if you got an MRI and CT because you're having back pain and shooting down pain, well, sounds like you're heading towards the surgical fix, because well else were you getting the imaging unless you're having the pain. But what that is essentially on the back part of the spine, we have something called the pars, P-A-R-S. You get a slippage of that if you have hyperextension injuries. Look, I'm going to have my huge spine model now. Hyperextension over and over. Gymnasts, tennis players, divers, football players, repetitive flexion there. Sorry, extension there, repetitive extension there. Get a little pop, get the fracture. Over time, that leads to disc degeneration, bone slipping on bone, nerves coming down, nerves being squeezed. So Carson, I just saw that question. Thank you so much for asking. How do we fix that? Well, it's my favorite condition to, there's so many spine models here. Favorite condition to treat, because there's no debate in a way on how to fix a pars fracture that's surgically indicated. It needs a fusion. The gold standard at L5S1, there's a great paper from Brigham Women's that showed that at L5S1, the gold standard might be aggressive. I don't want to get in trouble for those that don't do it this way. But a way that has extremely good outcomes compared to the good outcomes from the other way is doing an A-lift as opposed to a T-lift. And if you're at home being like, I don't know what either of those are, what are you talking about? One puts the cage in kind of going through the belly. One puts the cage in through the back. And if you're at home being like, well, I don't want a cage to begin with, so unsubscribe, fine. But if you have a slip, you have the fracture. Fractures need fusion, just like if your 4-year-old falls off the monkey bars, breaks his wrist on Friday and has to get a cast for 4 weeks, just like mine. Fractures need fusion, and you get stabilization. The stabilization, you have this small, little, cute, tiny, cute cage. I'm trying to do it so you guys can see it. I just hold it like this. My God, my fingers are too big. They're bigger than the cage. See, that's the T-lift cage right there. Nice, cute cage. Helps the fusion. Or if you go through the belly, here you go. You get a nice fat cage. Bigger surface area, bigger disc height restoration, less subsidence, less punching through the bone. It's a great fix for it. And then in the back, many ways to skin a cat here. The way I do it, I do a spin with the CT machine. I put on this big, bulky headset, and it's augmented reality. I make 2 stab incisions. For real, they're about the size of this black part of the pin. And goodness, I get so many patients, telemed across, and they're like, I heard you say the exact same thing in your live, and this is me saying it over and over again. But this black part of the pin, probably an incision on the left and the right side, back part of the spine. I use CT navigation. I use augmented reality. navigate these screws down. So if this is your spine, kind of on your back here, got me? On your back here, 2 stab incisions. All this is your fat, your muscle. And then under your skin, I do all this work under it. So in a nutshell, Carson, that's exactly how I fix spondylolisthesis from a pars fracture that needs surgery in that exact way. Probably do 3 or 4 of them a month. That's a great surgery, big surgery. Bola, I see you keep asking that question. I'll go to it from VBT surgery. Are you talking about tethering? Thoughts on tethering? Tethering, I don't do. It's usually more of a pediatric spinal surgeon. And tethering is a way to hopefully avoid pedicle screws in the adolescent population, those that are needing spine surgery, scoliosis that are 13, 14, 15, 16. My understanding of it is pretty much you need, just like in scoliosis for kids, you need to do it before they kind of go through puberty, before they have their big growth spurt, and then they kind of start hardening in that spot like we as adults have done. So you do the tethering kind of for those at home. You pretty much, instead of using pedicle screws and rods, you use a bunch of wires. You pull the spine in place, and when they do their growth, they grow in that spot. And so it's a non-fusion. Now, there are people out there, and I'm not trying to throw too much shade, that are doing tethering in adults for scoliosis. And I don't know if the spine community is super supportive of that. I would kind of caution people at home, anything that's cash only is because insurance doesn't approve it. Maybe there's a reason this insurance doesn't approve it. Now, to be fair, insurance companies are evil. I can go on and on about all of that, and they deny plenty of surgeries that should be done. So I'm not at all defending insurance companies, but when they're not approving on adults, and groups in New Jersey or wherever are like, well, for $90,000, we'll do a tethering surgery for your scoliosis. I don't know. It's a little bit of a different argument, but in general, tethering is indicated for adolescents, young teenagers before they go through there. It's a great question from Adam Taub. I have a fusion from T6 to T11. I might have to get fused the occipital. Yikes! It sounds like a pretty big surgery. Yeah, it's not. It sounds like a big thing of degenerative disc disease. From Healy, how long does an L4-5 fusion take? A lot of ways to do an L4-5 fusion. I would say anywhere from an hour and a half to 3 hours, just depending on if they're going through the belly and the back, if they're doing it all from the back. A lot of ways to do that surgery, but hour and a half to 3 hours, hour and a half on the earlier side. From Adam Taub, will I lose all my movement? You'll lose a very significant amount of movement if you fuse up to the skull. And patients ask me all the time, so when you get like a 2-level disc replacement, 2-level fusion in the front of the neck, and this kind of goes back to the future of spine surgery talk. Some of the things that I want to focus on in the future of spine surgery is keeping our level of fusion smaller from diagnosing the condition better. What do I mean by that? If you get a 3-level neck fusion, truthfully, maybe only 2 of those levels, maybe only 1 of those levels need to be fused. Now, that's a huge, broad generalization, but there's a lot of times for sure where I'm like, man, I'm positive this level, I'm positive in the neck that this level and this level are causing your issue. This other level looks terrible. It might not be causing your issue, but should we just fuse all 3 of them? Sometimes I pick that choice. For those that are my patients at home kind of watching, they actually see me a lot say, I know this level's bad, this level's not bad. Let's just fix what's the issue today, not both. In terms of the future of spine surgery, if we can get better at seeing should we just fix both now, just one at a time, that could help limit range of motion loss. For real, a 3-level neck fusion doesn't cause a huge amount of range of motion loss, assuming you're already bone on bone, assuming you already had the pinched nerves from the bone on bone and had a very degenerative neck. Look, if you're getting 3 levels of your neck fused, in general, you're probably older. What do I mean by older? 60, 70, 80, hopefully not 80. It's a lot through the front of the neck. You have a lot of arthritis in the back. You probably don't have a lot of range of motion to start with. So I see patients all the time that avoid surgery because they don't want to lose range of motion. And I try to emphasize on them, dude, you're bone on bone. You can even see your body's already fused that level. I'm breaking up that fusion and doing it in a better position. But that scares patients, and I get it. I don't want spine surgery myself. Going to the skull, though, I also tell patients, you get 50% of this motion, yes, from the skull and C1. You get 50% of this motion from C1 and C2. So in the overwhelming majority of my surgeries, over 99% of them, I'm not even touching the skull or C1 or C2, or usually not even C3. And so I'm like, look, I'm not even touching that area. And that's where you get 50% of this, 50% of this. And I'm not even touching it. So usually a 1 level and a 2 level fusion, there's not clinical range of motion significant loss compared to your preoperative state, but it's also based on the patient. If you're younger and you don't have a lot of arthritis, well, I'm probably not doing a fusion on you. I'm probably doing a disc replacement. So I know it's a whole lot. Again, these are all recorded. I put these all up online so you guys can go back and listen to these, because I know I do talk fast, but I also don't have a lot of time to do these live streams. So I try to get through a lot fast, and I apologize for that. Where am I located? Dallas, Texas. I'm speechless. What are your thoughts if a doctor told me the hour takes 7 hours from Pili? I don't want you to question your doctor. If they think if it takes them 7 hours, it takes them 7 hours. You know, maybe I have doctor time. Maybe it takes me longer than I think. But truthfully, I do many 1 level fusions in 2 to 3 hours. If they need 7 hours, you know, good. Take your time. I'm not trying to rip someone for taking 7 hours. That does seem like a long time for a 1 level surgery. I don't have a good answer for you. RFA. So sorry, a lot of things coming about 1,000 people in the chat. I'm trying to get to these. All right, from Mahir, any advice for Bertolli syndrome after injection, still having pain? So that's a good question. So Bertolli syndrome is on the back part here. These spinous processes can overgrow, and this one almost kind of, if it overgrows and grows into the pelvis, if it's an autofusion, then great. That doesn't cause any issue. If it doesn't, and it's like a pseudo joint, you can have a fake joint here, and then that in itself, that bone rubbing on bone, could cause your pain. So how do you fix that? Well, the future of spine surgery goes back to this. We need to get better at diagnosing that issue, better at looking at certain x-rays to see if you have that condition, and then have a better relationship with pain doctors that put a needle into that area, a needle to Bertolli syndrome, put some numbing medication there and calm it down. If that got you better, well, good. Now at least we have the diagnosis. If the injection didn't help, then maybe it's not your issue. In terms of how to fix it, it's tough on a lot of parts. You know, honestly, I've done 2 shaving off that bone, and it was hard, bloody, and a little painful for the patient. And it's not like super risk-free. And I've done several. We just did a 1 level fusion of the 5-1. You know, you're already kind of fused there. We're just completing that fusion. And I haven't done a ton since then because the insurance companies denied the surgery. They say no indication for fusion. And then it's just like a very huge, tough thing. It's like, well, now what do we do? Because they say that's not an indication for a fusion. They say it's experimental. And I'm like, well, shaving off that bone is dangerous, hard, bloody, might not work. It's already fused. You should fuse it. So I've kind of gotten a little away from treating those things just because it's kind of a lose-lose based on the insurance companies. Oh, goodness, what is that all from? What is neurogenic claudication and what can be done for it? Neurogenic claudication is a great question. Thanks so much for asking. If this is your lumbar spine on the back, you have severe joint arthritis. It causes pinching of all the nerves running down the tube. It'd be like a garden hose and squeezing that garden hose. That's neurogenic. That causes spinal stenosis. Neurogenic claudication is the symptoms from that spinal stenosis. So again, arthritis, rubbing, squeezing those nerves, squeezes all those nerves. Neurogenic claudication is almost like when you're out walking, and this is usually older people, out walking, your legs just get heavy on you because they're not getting enough nerve juice to them. Think of it that way. When you're out at a grocery store, Sam's Club, you have to be on a shopping cart, leaning forward to try to open your neural canal. That's also classic for neurogenic claudication. You get on a bike or a cart, it doesn't cause the same issues because you don't have vascular claudication. So you always want to rule out vascular claudication. So neurogenic claudication is a great condition to have in a way. Hear me out. You're like, well, I don't want that. Good condition to have because it's got good treatment options. You don't have to have a fusion just because you have neurogenic claudication. It's based on your x-rays. It's based on the bones and the bone slipping. Sorry if I'm a little distracted. We got Geta about to start his Tomorrowland closing set in the background here. And it's fantastic so far. So got about 80% of my focus here, 20 back there watching Geta do his thing. But no one pop off of this. You guys can go watch the YouTube feed of it in Belgium later. So look, bone, disc, bone, severe joint arthritis on the back that squeezes those nerves. Hold on really quick. Jack, look who's on. He's playing your song. No, look.
Are you filming?
I'm live. Everyone's live right now, but they're playing your favorite song. I was just thinking of you.
Yeah, I can take the card on the mail.
Oh, nice. Okay, let me back to it.
Open it for
Yes,
me,
sir.
please? Okay.
Do you want to watch this or no? He also likes David Guetta. You guys got to see a little family moment there. He just ran into the back. So a couple more things, and then we got to go. In terms of how to fix neurogenic claudication, if it's 1 or 2 level, it needs a laminectomy. If you don't have instability, if you don't have that bone slipping forward, it could just be a laminectomy. So again, a laminectomy, what is that? I do it in a fancy way, but doesn't mean it's better than anyone else's way. But I use this thing called an ultrasonic bone scalpel. Well, I make an incision about this big on the back. And for those at home, can't really see what my hands are showing you. So let me find a pin. Here we go. If this is a writing utensil, it's a pin about that big. And then on the back, I can make an incision, shave through the muscle, pull the muscle aside on the left and right. And then I can do the laminectomy with that ultrasonic bone scalpel. That's a fantastic way to fix neurogenic claudication kind of forever, and you don't need a fusion. Where am I located? Dallas, Texas. Seen a study that epidural steroid shots are not worth it. Is it true? From 24/7 Iowa. I have a lot of mixed thoughts. In general, look, I highly support steroid shots in the lumbar spine. If I was a patient who needed it, I would do it to not do it to myself. I would do it also. Now, there is some studies that show they don't. Okay, we got a kid freaking out here. Let's see it. Why are those all gold? Oh, sweet,
She
dude.
sent me a gold collection. Do you know how much these cost?
Oh, my God. No, I don't. Okay, let me finish this, and we'll go look them together. You want to show everyone?
Gold Pokemon cards. Oh, God.
Oh, God. Okay. Love you.
Goodbye. These are...
All right, let me get to a couple questions here, and then I got to go. So a couple questions here. I have they're coming through so fast. Sorry. I just had spinal fusion. This is from Cloud9. I just had spinal fusion lumbar spine. How likely is it the screws back out? Almost probably a 2 to 3% chance. Why would they back out? Is if you didn't fuse. If those bones didn't fully fuse at the disc space or posterior lateral, that's the only way they back out. It's pretty rare. All right, team. I'm going to roll. I'm going to go play with my kid. He just got home from his friend's house. If you have any other questions, you can always direct message me. Again, I'm a spine surgeon here in Dallas, Texas. I was hoping we could talk more about the future of spine surgery, but it's the summer. My kid's freaking out. We got Geta on it, and we're just going to go hang out while the other ones nap. And go ahead and follow me. Put on your alerts. You can always direct message me things, and my team will get back to you on how to set up telemed appointments. We do 30 of them a month. Patients fly from all over. Just rounded on one of my patients from Hawaii. He's my 3rd patient from Hawaii. That's, I think, the furthest. I have a guy from New Zealand. That's probably the furthest. New Zealand's probably the furthest away, but we do it all the time. Happy to take care of it. Turn on the alerts. I'll do another live here probably next weekend, but I'm going to go play with my kiddo.